disorder. And these are patients which are usually associated with CNS or renal disease, and the eye could be the initial manifestation. And the reason why this is important is your therapy changes aggressively, and you have to give these patients biologics or cyclophosphamide. So the next one is when you see a scleritis, are you seeing any obvious systemic disease? In rheumatoid arthritis, usually scleritis is seen over time, and it is not an initial finding, though you can see, but generally chronic cases land up with scleritis, and you will see deformities like this, like nodules, and you will see extensive dry eye because they would have already landed up with Joplin's kind of features. This is one of our patients who had relapsing polychondritis. So when we were examining by mistake, I just touched her ear, and she just winced in pain. So she had a severe inflamed cartilage. Now, sometimes these are very obvious, but you tend to miss in a busy OPD, like these Malnad rashes, these kind of skin lesions and vasculitic areas. And this is one of our patients with ANCA associated. You can see this kind of melt, necrotic, and sometimes they can just come with diffuse scleritis. Again, you can see the destruction of the cartilage, and you can see the vasculitic areas in the periphery. Now, this is a case who was actually referred by the dermatologist for episcleritis. And ideally, this would have just passed off as just starting with topical steroids. But if you invert them, you will actually see inflamed conjunctiva. And if you don't treat this with aggressive immune suppression, you will land up with symblepharon. So this is where it is very important to make a difference whether this episcleritis is significant or not. And these are cases where the immune suppression has to be increased. Now, I have pointed out cases which are very clear infection and immune, but you can have a lot of overlap in the clinical signs. For example, in this case, who had this kind of necrotic, just a thinned out sclera with a diffuse patch, but he all the time kept having increasing headaches. Things were getting better, and then he comes with one kind of a fistula in the conjunctiva. And then within a month, he was actually admitted. He had Acinetobacter infection, which was involving the lungs, and he landed up with a cornea like this. Now, this is a case which will actually pass off as autoimmune for me if I see initially, but this patient actually had a CNS tuberculoma and also had a lung involvement. This was biopsy. You had granulomatous inflammation, and this was positive for TB. And these patients need medications for more than a year. Now, an important other finding is the posterior scleritis. Earlier, we were localizing it to autoimmune, but we do see a lot in infections as well. As in this case, and they generally have an anterior component as well. So this is actually a tubercular choroiditis, but had an anterior as well as a posterior scleritis. And this is how classically it presents. You have dyschedema, subretinal fluid. You will pick up the T sign on the B scan. You can see chorioretinal folds on your FFA and on the UDI OCT. This is again another same case with rheumatoid arthritis with chorioretinal folds. This is a patient with viral retinitis. He initially came only with dyschedema and actually had a lot of pain. So it was misdiagnosed as probably an early PKH. But by the time I saw him on Monday, he had already developed huge patches. And this is actually a viral retinitis with posterior scleritis. So once we know that you're dealing with scleritis, you need to do a few tests to rule out infection and non-infection. And these are the different causes for non-infection and infectious scleritis. This is available in IGO, and that thing is not showing in the below thing. But most common causes of infectious scleritis are usually pseudomonas and fungal. And you can have rare causes like TB, sarcoid, syphilis, which can cause infections, but this is a whole range which can cause infectious scleritis. In the non-infectious group, you need to rule out connective tissue disorders, systemic vasculitis, medication-induced, and simple things like atopy, rosacea, gout. You can also have foreign bodies and chemical injuries which can cause scleritis. So this is a range of investigations which you need to order, and this is actually the order for all patients with scleritis. Most importantly, because these are simple tests which you can do to detect systemic vasculitis. So if they have FAS or albumin in the urine, then you know you're dealing with an autoimmune component or something like a connective tissue disorder or systemic vasculitis. And again, depending on the type of inflammation which you're seeing, you can tailor your special investigations accordingly. Definitely, your anterior segment OCTs, ultrasounds, UBM, OCT, FFV, ICG are ancillary investigations. Now, when you see a pus pointing, generally you try to explore that area, and this is one where it's very small point, and sometimes this is so small that by the time you pick it up for culture, everything goes negative. So PCR is a good option which is there these days, where you can take whatever sample you are getting. We don't even use a cannula now, we just go in with the half of that syringe and try to take whatever is available and send it for PCR. So once you know you are dealing with either an infection or a non-infection, you treat them accordingly with antibiotics. And it is important to remember that bacteria especially are associated with a lot of immunological reaction, so you have to give them steroids. And in non-infections, of course, steroid is our mainstay, but we've started using more and more of DMARDs. We normally prefer methotrexate, but in cases refractory to methotrexate, we add mycophenolate or we give a combination. We have passed the era of azathioprine or cyclosporin and tacrolimus. Nowadays, if they don't respond to this combination, we move directly to biologics. And our preferred biologics are adalimumab and rituximab, and of course intravenous cyclophosphamide. Generally, we reserve this for those cases which are refractory to the conventional DMARDs, or if they have a necrotizing variant, or if you see a peripheral corneal disease. Now, this is a very busy slide, but what I would like to highlight is when you see scleritis, you're dealing with either a granuloma formation in the sclera, which is causing a destruction, or you're dealing with an ischemia, which is causing necrosis. Now, generally, there are few inhibitors, mediators which are actually involved, and that is the TNF alpha and the B cells. So that is the reason why we use rituximab, which targets the B cells, and we use TNF, that is adalimumab, which anti-TNF agents, which targets the TNF thing. So generally, we reserve the B cell inhibitor for systemic vasculitis, and for the granuloma formation, which has a lot of TNF formation, we generally prefer adalimumab. And also, it's easier to do adalimumab because you can give it every 2 weeks, and things are not responding, you can always shift. But once you give rituximab, you may not be able to give anything for 5 to 6 months. So this is interesting newer insights into scleritis, where they're looking at inhibitors of these matrix metalloproteinases, and sometimes we also treat these patients with doxycycline if they have a lot of rosacea, and because these are disease-modifying drugs. So this is a case I had shown you earlier of a collagen vascular disease. Basically, eye involvement was the first manifestation, and he was treated with cyclophosphamide, and the whole thing responded very well. This is a P anchor, started settling down with cyclophosphamide, and this is Wegener's, which settled down very well. So, but you need to be careful also, because with the newer biologics like rituximab, you can have worsening of inflammation initially, and this is one of our patients with pseudotumor with GPA, and he actually had a worsening of scleritis because there is a sudden destruction and increase in inflammatory mediators, which can worsen the existing inflammation. So you need to keep that in mind. This is a patient with SLE, and initially she just had that temporal episcleritis, but after rituximab, 2 weeks down the line, she landed up with a corneal infiltrate like this. And eventually we had to put her on IVMP, and then things settled down after a long period of time. Now sometimes the rheumatologist will feel everything is under control systemically, but you will still see this kind of inflammation persisting. And this is when, as an ophthalmologist, you should take a call and you should order your rheumatologist to say that this patient actually needs more immune suppression, and this patient was given IV cyclophosphamide, and the whole thing resolved beautifully, and now she's 4 years down the line and everything is stable. But I would like to share, we are dealing with dangerous drugs, although they have made a big difference in our treating these patients. This is one of our patients with rheumatoid arthritis and develops this melt. And when we started her on IV cyclophosphamide, she eventually develops a secondary infection over time. And eventually we had to stop cyclophosphamide and just keep her on oral steroids, and things settle down over. They take their own course, but this is something which you need to keep in mind, especially in elderly and in a country where we see a lot of infections. I would like to just end with this challenging case. Again, a history of FICO with vitrectomy done for a ERM. And she was referred from Chennai, and by the time I saw her, she was already investigated, received IVMP, and she was already on MMF. And but when she came to me, her blood sugars were high, and I was attributing it to the steroids. But what was puzzling for me was a headache. So in spite of all this, her headache was just not getting better. And this is how, when I saw her, this is something very difficult to digest that this is an autoimmune reaction. It looks more infective to me. And this later turned out to be a small kind of a pus pointing area. So we biopsied that, which came out negative. And so since the headache was so prominent and this finding was so prominent, we put her on a broad spectrum antibiotic and she was on it for at least 4 months. So things improved initially, but each time I would reduce the steroids to 20, she would get back a new patch. And that's when she could not tolerate steroids anymore, and we put her on MMF. She couldn't tolerate methotrexate because she had some drug-induced reductions. So she was on MMF, and things were getting better. But each time again I would reduce the steroid, she would come back. And at this point of time, we said, let's go give her cyclophosphamide. And this is after 2 doses, I see another pus point in here. So this is when I think you should stop and go back and re-explore. So this patient had already 4 biopsies done and all were negative. But this time we thought, let's just send it to PCR. And this actually came out as Haemophilus influenzae, which are actually encapsulated organisms which respond initially well, but later on they develop resistance to that and you need to actually give a different type of antibiotic. So if you know the organism, it is much better. And nowadays our diagnostic technologies are such that you can pick up the organism. And this patient was treated with subconjunctival injections, intravenous injections, and things started getting much better. And this is the eye which I saw recently, everything under control. I've removed her off steroids right now. But an important difference which has been in our practice is a multidisciplinary approach. We are starting to involve other fields of medicine, especially rheumatology, in our treatment of these patients. And as a result, it's a mutual give and take. And the patients have had a better visual outcome and a better prognosis for life. This is just a flow chart. This is available in the IJO and which you can look up. In the interest of time, I'm only going into it. So with this, I hope I could give you a glimpse on how to approach these cases of scleritis, and I warmly welcome you all to the coming year of Annual Uveitis Society of India, which is going to be in Abu Dhabi this year. And we have an interesting faculty with a lot of lineup. And for people who are USI members, please do write to us for a lot of discounted rates in registration. And I thank you all for the patient here.
Thank you for the comprehensive session, ma'am. We may have time for a couple of questions from the audience.
How common is tuberculosis, nodular scleritis? They turn out to be quantified on TB gold positive and mantle positive.
Yeah.
They actually give them the whole 6 months course of ATT and steroids. Is it really that common? Sure.
See, the reason why I showed you those 2 slides of that TB was an eye-opener for me, because I had never seen TB presenting as an infiltrate kind of a pattern. And generally we do see with the scar. So normally if you see a scleritis with the scar, which is not in continuation with the limbus, like you have space between the limbus and that, definitely TB and granulomatous diseases like leprosy and syphilis are high on the list. We are seeing more and more cases, but we are seeing cases which, basically in scleritis you have an immunological component. Unlike what you would see with a retinal disease where you can have an infection directly. So the scleritis part may take time to settle down, unlike what you would see with a choroiditis or that kind of. But it is common, and we are probably learning to pick it up much more thanks to the literature which is already available on identifying certain clinical phenotypes. So this has been there for a long time, and now we are picking up these signs. So Definitely, I think for ocular TB, we treat it as an extrapulmonary and we have to give a year. But if it is associated with the CNS component, like the case which I had shown, at least 15 to 18 months is what is recommended. I hope that answers.
Madam Chair, for this related to tuberculosis, what are clinically we can pick up the ocular signs because we cannot prove that tuberculosis anyway in ocular. This empirically we treat, but it improves. But at least the external segment or question segment, what you are encountered in your practice, common things.
So the case which I had showed had actually initially come, which is the sclerosing keratouveitis kind of picture. And when my cornea person showed me, I just told her, just treat it with topical steroids. And she kept saying, quantiferon is positive, man2 is positive. And I was just saying, because this is not a described sign for, in the sense where we have to start treatment. Because still, unlike serpiginous choroiditis, where we know the phenotype is very significant, this is something which we are not sure still. But interestingly, once we had this case, over time when we started seeing him, he started developing these RPE alterations in the fundus. And that is, I think, short that there is something else which is going on. And that's when we got a CT done. He had a few lymph nodes in the lung. And that's when we decided to, go ahead and start him on anti-TB therapy. PCRs have low sensitivity and specificity, so you may not pick up. But in my practice, what I have seen is, I think a HRCT makes a big difference. So if you have a patient with recurrent involvement, inflammations which are a little atypical, and you have a corneal involvement like the ones I have shown, I think it is important to get a HRCT, and I think it is worth giving them a course of anti-TB.
That's anti-TB, okay, but what about the steroids? It will give me some.
No, steroids are known to be given in TB by not only the eye, even the lung and other involvements as well, because it's associated with a lot of immunological reaction. So as long as they are covered with anti-TB medications, you can give them steroids. We even give IV methylprednisolone. So steroids is not a contraindication for me in patients with TB if they are under good cover of anti-TB medication.
What is the recent quantum medicine and energy medicine? They say all these things are psycho-neuro-immunological and psycho-neuro-endocrinological. Do you have any experience?
I think the whole uveitis and scleritis has a lot of psycho component with it because we are seeing more and more in younger patients these days. There's a lot of stress component. I remember I had a patient with sarcoid, and so she refused medications. She went to the US. Unfortunately, she had to start all the medications there. And she came back doing a PhD on lifestyle changes with in patients who are with autoimmune diseases. And actually, I'm happy to say that she has made a big difference in many of my patients with autoimmune disease. Because if you look at the ancient, traditional methods, there is a lot of emphasis which is laid on gut. When you look at Ayurveda or anything for that matter. We have noticed, though, there are studies now because of the microbiome changes causing these involvement. We have noticed a good amount of changes occurring in patients in terms of recurrences coming down, remission coming much earlier when you alter the gut flora. So there's a lot of emphasis now which has been paid to alternate medicine in form of gut-related and yoga and meditation, especially viral-induced autoimmune HLA-B27 related diseases and SAV made a big difference. Actually, in fact, there's a study also which is going on between the rheumatologists and us, and the Ayurvedic thing to look at. But these are probably secondary therapies. I think still we shouldn't ignore that we have the weapon with us and we have to treat this, and these things should go hand in hand to reduce the amount of recurrences of. I think there's a big study going on with NIMHANS right now, with neurological diseases and.
Whole scleritis is not a local disease.
It's not.
So is it the whole body is involved?
Yeah.
We are still lacking in finding out where we.
Yeah. But definitely, at least we are not seeing cases of scleromalacia as much as what I would see as a PG or a fellow. So that's definitely a big drastic change which has occurred. And scleritis per se, I think the lifestyle changes are much, in the sense the quality of life is much better than what it was probably 20 years with the newer medications.
We may have time for one more question.
Post-scleral birthing, we will come with patients who have some infection or the suture. They come to your place, so there must be an element of scleritis. And sometimes you do see those pus points.
Correct.
What's been your experience in
Yeah, I've burned my hands also multiple number of times. They are very indolent, that's the problem. And these are not the common organisms which we see. We have treated patients with cyclophosphamide also. That level we have gone up till, and then realized once you start medications, you see a pus pointing, and then you pick up the thing. And now with the PCR, a lot of things have changed. At least you're able to pinpoint the organism and treat it. But we've had issues with buccal infections, where the thing is, if you can remove that suture and send it for examination, that would be very ideal. I think the take-home message will be to give a broad spectrum antibiotic for a reasonably long period of time. When I say reasonably long, at least for 4 to 6 weeks. And if things are not settling by then probably you will need to, because you will be giving steroids anyway with it. So if it is not flaring up, I think this is probably that if you don't see a pus pointing or anything. But I think that headache is something which is very significant. And when I hear a patient saying that over and over again, I think that kind of triggers an alarm bell. So you have to keep in mind infections.
If you don't come up with an organism, is there, like you said, the cross spectrum?
Yeah, usually it's ciprofloxacin at 750 and Lister. And they do well, generally they do. Like even in that case which I showed, initially it was okay. And then only when you reduce, that's when you have a problem. But broad spectrum antibiotics are good unless you're dealing with a fungal. That is always dicey too. So that we keep monitoring for anterior uveitis or posterior segmental V scans, just see, even if you see a little bit of flare or cells in that, then we have to do a tap to send it for fungal. So that's the only place I think we really have an issue still. But bacterial, by and large, things are much better than what it used to be.
Thank you very much, ma'am, for
We
using
have a
explaining
Q&A session at
to
the
us.
end, so we'll kindly move on to the next session.
And I also request everyone here to please turn their phones off or put them to silent mode. Moving on to the panel discussion we are about to have on uveitis, it gives me immense pleasure to introduce the moderator of this session, Registrar in Medical Retina and Uveitis, Sankara Eye Hospital Shivamogga, the delightful and dedicated Dr. Sujita. I also invite onto the stage our panelists, Dr. Kalpana B. Murthy, Dr. Ravi Shankar, the head of Vitreoretina Department at Sankara Eye Hospital, Dr. Puneet Isnur, consultant Vitreoretina and Sagar Nursing Home, Shivamogga, and Dr. Pradeep Sagar, consultant Sankara Eye Hospital, Vitreoretina Department.
Yeah, I'll be presenting few interesting cases. Coming to the first case, here is a 59-year-old gentleman who is non-diabetic and hypertensive since 3 years, presented with pain, redness in the right eye, 2 months, following an uneven sutureless vitrectomy for TRD emerging myopia. He was off medication for 1 month ago, And when he presented to us, there was a deep congestion localized to the inferior temporal port side with an audible elevation, as we can see here. So at this point, we thought it could be a surgically induced nodular scleritis. So we restarted him on topical steroids. And patient at 1 week of follow-up reported improvement in the severity of pain, but there was no significant difference clinically. So again at 2 weeks of follow-up, he again presented with pain and redness. At this point, we noticed there is an increase in congestion with the yellow nodule. So we thought of an infective etiology and went ahead with a scleral biopsy. And during scleral biopsy, there was no foreign body or pus, and the histopathological examination suggested there was it was rich in inflammatory cells, but the section was negative for granulomas. Diagnostic PCR was negative for most of the bacteria, and KOH preparation and gram stain was negative. Tissue culture showed no growth, and this is a post biopsy day 2, and he was on topical steroids. At 1 week of post steroid biopsy, you can see there is a reduction in the congestion. And again, we reconsidered our diagnosis of surgically induced scleritis and started him on oral steroid therapy. So at 4 weeks of follow-up on topical medication and oral steroid on tapering dose, we can see there is a significant reduction in the congestion. And again on tapering it out to the lower dose, at 8 weeks of follow-up, we saw there is a recurrence of congestion with a scleral nodule at a newer site. So at this point, we considered for rheumatological evaluation and started him on topical prednisolone and cyclosporin 2% drops. And the rheumatological evaluation, most of the investigations were within normal limit except for the quantiferon TB group, which was positive. So we referred him to the rheumatologist, and in view of quantiferon TB being positive, rheumatologist opined to start him on anti-tubercular therapy and systemic steroid and avoid immunomodulatory therapy. So again, after 2 months of follow-up after anti-tubercular therapy, there was minimal decrease in the congestion, the nodule still persisted, and now there was a new onset of nodular scleritis at a new site. So he was continued on the topical medication, and in view of new onset of lesion, we referred him back to the rheumatologist to start immunomodulatory therapy. But rheumatologist opined to start immunomodulatory therapy after 3 months of anti-tubercular therapy. After 3 months of anti-tubercular therapy, and we see there is a resolution of congestion and resolution of the nodule with a scleral thinning. So I would like to ask our respected panelists to opine regarding few queries. Here, I would like to ask Kalpana Bakuma, what could be the etiology or any other investigation should we have considered?
It's an interesting case, and I think most of us face this quite in our practice. But this is quite similar to the case which I had shown earlier. And what I can see clinically, it looks like an infective organism because each time you take the steroid, it is coming back. The whole thing, the way it is fleeting, everything looks more in favor of probably an infection to me. And maybe the infection is something which is indolent, which is not something which is very aggressive like a pseudomonas or something. So that would be my first thought, post-surgery, and then you have this. So what I would probably have done is probably I would have been a little more bolder and started on immunomodulation if I had that doubt. Think because TB for me here will not come into the picture as a first option here at least. So the areas which are biopsied, generally what happens is it's so tiny that by the time you pick it up, it's already gone. So most of the time, the pus areas you never pick up anything. So this is when actually this was taught to me by Dr. Krishna. Actually, he said, let's just go in with just the then you pick up whatever you get and then send it for because the chances of you getting things are much, especially when you have a pointing area like this. So I think that is one thing probably you could do in terms of sending it for PCR, and this would be an indolent, or you can probably start them on broad spectrum antibiotics. Now, in this case, we don't know because the whole thing settled down by itself. But what you should remember is that ATP, which you have started, is also an antibiotic. So we really don't know whether that had some role to play in terms of the, since the organism is so indolent, probably it was working to that also. So this is one thing. Regarding, what I would like to, with the way the whole thing worked is probably that, and things have not surfaced back after some time. But what is important is, for immunomodulatory therapy, at least the conventional, we ignore the quantiferon actually. In fact, we kind of follow up these patients with a chest X-ray maybe after 3 months after starting immunomodulation, because now we treat methotrexate and MMF as safe drugs. You really don't need to look at the quantiferon to decide whether you want to start or not. If your scans in the lung are absolutely fine. But if you're starting these patients on biologics, that's when I will be concerned about the quantiferon TB. So that is when I will need an anti-tubercular therapy, which has to be started, say, 2 or 3 months, and not for a conventional BMA. Because generally, if you look at all ours, quantiferon is always, so it's very non-specific. In the absence of a characteristic clinical phenotype. So if nothing is working, then probably I would take a shot, but I don't think so. Not in this case.
Thank you, ma'am. So another query I would like to ask Dr. Puneet is, sir, should we avoid immunomodulatory therapy in cases of uveitis, which are not suggestive of tubercular etiology clinically, but we come across quantiferon TB codes being positive? Just now, I think ma'am has answered this query. So we'll move on to the next question, that this patient requires cataract surgery in the same eye and patch planar vitrectomy in the other eye. So when should we consider these surgeries, and what are the precautions to be taken during the procedure?
How significant is the vision drop? I think that's
3 by 6.
So if it is 3 by 6 again, because of the retinal problem, you will have to see the fundus. But I would still like to wait for 2 or 3 months. Just wait, because I don't know what is happening still, whether it's going to come back. So at least a couple of months at least, if you can wait and see how the patient is doing. And also keep a watch on the headaches. So the patient may just come with a diffuse congestion, but the headache is quite significant. So if you feel that the headaches are increasing, then I think infection is on the higher. But if I can hold it, I would probably push it for 2 or 3 months till I know what I'm doing.
He has the poor vision with the other eye also.
Yeah, you could go ahead with the other eye. Probably I would just get an anti-nuclear antibody and maybe a rheumatoid factor just to be on the safer side in case I need to start anything.
It was negative.
It was
It's
normal.
normal.
And probably urine is also absolutely fine. If those are okay, then I think I will go ahead with that. But counsel them, because nowadays I think the medical legal, they just come back to you and create an issue, but we counsel them drastically. We tell them about all the possibilities to the effect that it could be really bad. There are people who just turn back, but generally people come back because nobody else takes up these cases. But and then they are very happy when nothing happens. So in fact, the happiness quotient goes up very high after surgery. So I think it's a psychological fact. Like when the patient knows that you care for them, I think they understand what you're trying to say. But I think you should tell them that because of an inflammation in the other eye, there is a chance that this eye can have a similar inflammation in the But I would take them up only if the vision is really down or if there is a retinal problem which I cannot see.
So the take-home message from this case is it's better to consider the systemic evaluation even if we consider the diagnosis of surgically induced scleritis. And as
I think my take-home will be rule out an infection and then you look at the systemic impact.
And better to wait till the inflammation subsides before going ahead with another procedure.
Just one more query. We usually use white light, 80 white light to close the pores. So sometimes you find that after 1 week, it's a lot of redness around that area.
I had a customer a month also, and I keep telling my VR people, why do you just leave it like that? They have those foreign body granulomas which come. So we keep them on topical steroids along the people. Actually, in fact, I think many of our surgeons feel just leave it like that, put them on Uvitis. I mean, it works for each one. When I see a red eye, I am concerned. When you guys see a red eye, it doesn't matter. So, generally, I think if the patient is not very symptomatic, I think the take home would be just leave it. But if he is symptomatic with a lot of irritation, then maybe I would just add a course of low dose steroid for a while.
And do you prefer prednisolone or dexamethasone?
I'm very comfortable with prednisolone acetate, and Dexa I usually use only for chili. But my thing will be either fluoromethalone or prednisolone. And with inflammations like these, they are very simple. You will need prednisolone.
When how can we prevent this situation in another age, in the same patient? The second is how can you prevent in next cases? So now it some trauma triggered this situation. Now can we do some prevention in the next subsequent 100 cases?
Yeah, I would request Ravi Shankar sir to opine that.
You never know, and you have to take it. That's what I was trying to say. It depends upon how bad the vision is. If the vision is
I don't know, nobody knows, but we have to think this way because we are doing everyday health. And what is the systemically in that particular individual? What are the factors? We have to look for another individual.
now, see, this is one in a, it's not happy. It's not a routine thing that happens. This case, we keep doing so many vitrectomies. Not all of them end up with. So once you come up with something like this, the reason to put it up was to see how to manage it because honestly, we were quite puzzled about what it was. Every new lesion coming up and, a patient having severe pain. I mean, he was like, what ma'am was saying that he said, just take my eyes off you. He was in such sort of pain. Fortunately, that now has completely relieved. So that's a good sign. And that's what I learned now that, his headache has completely relieved.
So usually when we had a Beco flu infection, every whole world is now aware that how to prevent it. So we thought of the solution. Similarly, here,
No, but there are certain things which can't prevent. If you are following best clinical practices about the surgical practices, everything else, and still these things do happen. So there's only that much that you can control. You can't control
if
everything.
you look for any subclinical infection, subclinical bronchial infection, the subclinical,
But nothing was found. That was nothing was found.
still positivity.
They still a
I think yours is a point because sometimes we underestimate many things which they have, like asthma and kind of lung infections. Yeah, the case of hemophilus I had was actually not hemophilus, Acinetobacter. He was constantly using inhalers. So these are because all the infections are hematogenous. So they come directly from the blood or very rarely you have from direct infections. So I think it is important to probably if you have one case to look at basic parameters like check for diabetes, check for lung asthma related. Is he using any other basic loan for infections? I think that is something which we could do. Yeah, for me, actually, my cornea people will like, disagree with me because they love the topical immunomodulators. For me, it doesn't work. It just doesn't work. Whether it is cyclosporin or tacrolimus, it doesn't work because generally this is predominantly systemic. Unlike probably what you see with Werner Kepka, which is so beautiful with tacrolimus and base acids, but with, in my experience is that. I mean, others may differ, but not.
Regarding the same case, actually, we had also come across a kind of repeated knowledge development. But the first biopsy didn't show any vision. But when it came to the other side, we took another biopsy and implanted the same thing with OT system or drug alert. So that is when we got a good
biopsy is coming negative, I better implant directly in the OR we don't risk that transportation. You absolutely don't. That's what we do as well. And the problem is biopsy was done, would it reveal anything? So if we had done a second biopsy and then gone for other things, would it be better? In which case?
Yeah, if it's the first biopsy of negative, is it worth doing a second biopsy?
Yeah, we repeat it. Every time I change medications, I repeat it. And in fact, the patient gets so bad how many times you take her. But I think here it makes a big difference. This and the other one is CNV antibiotics. So definitely it makes a difference because the chances, the material is very little. So it's, the chance that you can miss it is also on the high side. But fortunately now with the PCR, and we are able to species tell us what it is. It has made a big difference in the management of infectious scleritis. Otherwise, by the time we would see the corneas involved, we end up with a hypopure, that kind of thing. Sometimes we do get that cyclophosphamidis to kick in and see if there is any infection, then it will show up. And that's when you treat it. And generally they settle down post that. But this is a little risky thing to do. But at that point of time, we have no other alternatives.
How do you counsel these patients? How do you go about counseling?
What's the right?
No, when they are repeating the procedures and.
We have to just tell them head over that we have to send it for
It's all the same.
We are used to it.
No, I know.
Repeat surgeries we do, repeat biopsies are nothing.
Whether she has any other technique of
Topical tacrolimus I use. The patient is responded.
cornea total like
Cornea. No. The reason we started, I mean, because we were desperate because the physician dermatologist was not allowing us to start, IMTs or anything, and we knew that, I mean, there was information, so we wanted to give something desperately, so we just tried it out. I don't know whether it worked or not. It's difficult to say. We don't know what worked finally, but something worked, and now the patient is okay.
And what are the systemic evaluation can we do before going for other eye surgery in the situation?
The systemic evaluation has already been done, sir, and nothing has been found, nothing significant has been found. We got a physician evaluation done. Tests, yeah, tests have been done, proper total evaluation has been done. Everything has come out except for the quantiferon TB, which, like ma'am said, may not be very reliable and we may not be like much of it. So that was the query, when to do the next surgery, because the patient has poor vision, not very good vision in both the eyes, so we need to go ahead with the other eye surgery.
So we'll move on to the next case. So here is a 26-year-old gentleman who presented with sudden diminution of vision in both the eyes since 3 days. His best corrected visual acuity in right eye was 636 pass and left eye was 612 pass. Anterior segment showed no evidence of inflammation, and this is a fundus picture showing the altered sheen at the macula with few white dots here. And the OCT showed loss of an outer retinal layer with fuzziness and nodular appearance of RP and a few hyperreflective dots in the choroid, in the both eyes. So we went ahead with fluorescein angiography and fluorescein angiography. We saw there's a punctate halofluorescence in the early phase with vascular staining and bleed at the late phase, which is more prominent in the left eye. So on general examination, he also had this erythematous mildly infiltrated flock-like lesions with few staining, which were present both on his feet and hands. So at this point, we thought it is chorioretinitis, possibly syphilis being the etiology. So we have referred him to the dermatologist, and dermatologist opined that the lesions probably altered because of local steroid application, and there were no genetic lesions. And we investigated him further, and we found that the serology for syphilis was positive. So we further evaluated him for the neurosyphilis and it was normal, and we advised an intramuscular injection of benzoyl penicillin 2.4 million international unit once a week for 3 weeks and oral doxycycline 100 mg twice a day. So this is after 3 days of first dose of benzoyl penicillin, the best corrected visual acuity improved to 612 and 6/9, and we can see there is a resolution of RPE nodularity on the OCT, and at this point we started him on systemic steroid of prednisolone 40 mg per day. After 10 days of completion of treatment, we can see his skin lesions resolved, and on fundus there was normal macular sheen, and his best corrected visual acuity improved to 665. And OCT showed restoration of the outer retinal layer with few areas of ether loss and resolution of hyperreflective dots in the forehead. So typically a syphilitic chorioretinitis presents as a yellow placoid lesion in the posterior fold, but which was not seen in our case. In our case, the multimodal imaging like OCT and fluorescent angiography helped us to come to a diagnosis. So, my query to panel members is when should we consider oral steroids in syphilitic uveitis if an individual is immunocompromised?
So this is a very classical thing of an outer retinal involvement. So wherever we see an outer retinal involvement, our first differential is always syphilis to keep in mind. Interestingly, your patient had it on the retinal aspect. Generally, it's only in the sole and the palm, and you really have to ask him to the thing, but the characteristics have to be similar. Now, whenever we see that, I have never really had to give steroids in these patients because they do very well with penicillin. The problem is you have to give crystalline penicillin, and that is not available in a regular setup. So in Bangalore, we refer them to Nimhals, and there they have the government thing, they generally have penicillin. So here, if you don't have that, then we give benzoyl penicillin, but we give it every week for the first 3 weeks, and then you give it once a month or something. But what I would actually have done is, in these patients with BDR positive, if it is positive, they give you an RPR titer. So that is important actually because you can assess your response depending on the titer. And with treatment, the titer comes down. And especially with immunocompetent patients, immunocompromised patients is very important because they can develop a chronic inflammation. So they just have retinitis and nothing else. But if you see that RPR titer will never come down. So these are patients who require long-term penicillin. So every month we need to keep taking penicillin. So the plus point of syphilis is we really don't need steroids because with penicillin itself you can see the response so well. But they are associated with paradoxical responses also, and that is the reason why we may have to give steroids if such a thing happens. So in an immunocompromised patient, that's the only difference will be the CNS I would check. They generally for a immunocompetent patient, if they don't have any CNS symptoms, you don't really need to do a neurological CSF examination. But if they have a CSF involvement, then you have to treat them in a different line altogether, like a neurosyphilis. But in an immunocompromised, it is taken that they have neurosyphilis. So that will be the difference, and you will do your treatment accordingly. So here I wouldn't treat the patient on my own. I would have an infectious disease person also with me. But generally their immune status is quite good. So you can give them steroids, but they will need continuous monitoring.
And my another query is how frequently should we repeat PR titer and how
We normally do it, I think, after 2 months I repeat it. 1 or 2 months you can repeat it. But if for a neurosyphilis, you have to do it 6 months. 3 to 6 months. You will see the titer dropping. And if you see a fresh inflammation, fresh flare, you have to repeat the titer.
Thank you.
And you have to treat the party. That is the most important.
Thank you. Any other queries? One more query is, ma'am, sometimes we see very hexamer-like reaction in patients with syphilis. So that's the indication where we need to start steroids.
It's a paradoxical reaction what you're seeing. That time we need to. That we see more with the placoid patients, not with this. funded kind of image. Even the placoid settles down beautifully with penicillin. If you treat them adequately, we never really had to give steroids. I think only one case I had to give steroids, but otherwise generally they do pretty well.
So, can we take it as a to take home that we generally start them only on penicillin and if necessary, if they develop a reaction, start them on steroids?
They give it seven. They give it twice or thrice, and I'm not very sure, I've forgotten. But we cannot give that. We send them to a government hospital, and in Bangalore, I think Malnad stays. So they finish the treatment and then they send it back to me. Unfortunately, now even that is becoming a problem. So now they're all starting penicillin. The problem is intrathecal penetration is not good with penicillin. So that is the reason for neurosyphilis it becomes difficult. So doxycycline is a good option. So though it is not a fully consensus thing, but we do give ceftriaxone or doxycycline.
The take-home message from this case is a thorough clinical examination can give us a clue to the diagnosis. As in our patient, the skin lesions helped us to arrive at a diagnosis, and a high index of suspicion is required to diagnose syphilis, and multimodal imaging is an appropriate diagnosis.
Thank you for the insightful. Thank you for the insightful discussion. Roshni Gupta. She did her fellowships at premium institutes like L.V. Prasad Eye Institute, Hyderabad, John Moran Eye Center, Utah, and Plastic Eye Surgery Associates at Houston, Texas. She set up the first and largest oculoplasty service in Karnataka in 2004. She has received several accolades and honors, including Best Paper and Best Video Awards, at platforms like OpenAI and AIUS. She is currently a visiting surgeon at Manipal Hospital, Trustwell Hospital, and Rangadolai Memorial Hospital in Bangalore. It is with great honor that I call upon you, ma'am, to talk about facial tics and faces.
Thank you for that very kind introduction. And I want to thank Dr. Kavita, Dr. Usha, Dr. Sujitra, and Sankara Eye Hospital, Malnad Ophthalmic Association for this opportunity to be here with you. It's a privilege to be here. And start the. So the topic that was given to me is essential lessons. Conditions. These are my former affiliations and I have no financial interest in the products. I will be showing full facial photographs of patients, but in all cases, permission has been taken from the patient. So we'll be talking about essential blepharospasm on these subheadings: the clinical features in epidemiology, supportive therapy, chemodenervation, and surgery. So I get to see a lot of patients with multiple kinds of things, but this young chap with a little baby vermiform movement of the lower lid, which comes on suddenly and is self-limited, this is an orbicularis myasthenia. Okay, and this is going to start off in patients, young patients with inadequate sleep, overstressed. An elderly lady, just now it's working. Try it out if it's working. So an elderly lady with spasm on one side of the face would be a hemifacial spasm. Whereas a lady with frequent blinking, frequent spasm of the eye, and you can actually see the rest of the face is also kind of spasmed, that is an essential blepharospasm. So roughly I remember this diagram. If you see one half of the face, we are talking about a hemifacial spasm. If you are seeing both eyes, that is a blepharospasm. So it was almost half a century ago when people actually talked about what blepharospasm is. And it was proposed that it's actually a type of focal dystonia. But the first depiction of facial spasm was in the 16th century. Flemish artist was Peter Bruegel. This famous painting is actually called the yawn, but it's not a yawn. You can see the spasms, and this is oromandibular dystonia. There are multiple focal dystonias described. However, current understanding is blepharospasm is part of the spectrum of focal dystonia. We don't still know exactly what causes it. It could be the basal ganglia dysfunction, or it could be sensitization of the trigeminal system. But it's very often combined with orofacial dystonia. That means both eyes and then both sides of the lower face. Or oromandibular dystonia. That means along with the eyes blinking, there will be abnormal movement of the jaw. They'll open and close their mouth. They'll move their jaws from side to side. So it is a rare condition. There's a definition of orphan diseases. It's less than 5 per 100,000 people. And blepharospasm comes into that category. And the mean age is about 5 to 6 decades, and most of the patients are female. There's a very small proportion of genetic component, but it has incomplete penetrance. It's very rarely that you see a patient having the next generation also affected. The most commonly identified are the motor features. We start off with difficulty in opening eyes, which is also called apraxia of lid opening. But this is never seen isolated, it's along with blepharospasm. And because the patient is unable to open the eye, people might call it, okay, is this myasthenia? Is this ptosis? Okay. There will be frequent blinking, and then this is confused with dry eyes. Typically, it is bilateral, but about quarter of them might start off unilaterally and then go on to the other side. 1/3 of them use sensory tricks. If you see them, they're going to pinch their forehead, they're going to press on their eyebrows. The sensory tricks dampen the spasms. They can sing, they can hum to themselves. Talking depresses, makes the spasms subside, and they also benefit with rest. In patients, the symptoms will worsen with time, unfortunately, and even those who start isolated to the eye, more than 50% will spread to the lower face and maybe even other parts of the body, the neck, the shoulders, and so on. What we don't pay so much attention to are the non-motor features. The patients will complain of dry, gritty sensation, pain, photophobia. they're anxious and depressed, they have insomnia, they have panic attacks. And almost 20% are misdiagnosed. Even the ones that are diagnosed often have been going around for more than a year, and sometimes even 4 to 6 years. See, for example, like I said, multiple symptoms are mistaken for other things. And when they're talking about anxiety and depression, and when they talk the spasm decreases, people might mistake it easily for a hypergenic dystonia. Now, one of the understandings we used to have earlier is that dry eye causes blepharospasm. However, blepharospasm itself is very often associated with dry eye. Okay? About 3/4 of them have dry eye. There's a decrease of tear breakup time. However, it's very difficult to measure because the patients are blinking very often. Occasionally, there will be frank filamentary keratitis. And any kind of stimulus, the wind, the dust, those things are going to increase the frequency, amplitude, and intensity of the blinking. So even in an essential blepharospasm, if you apply topical proparacaine and make them sit for some time, the blinking decreases. It never goes away fully, the blinking will decrease. And almost 100% of blepharospasm patients have lid viper epitheliopathy. This is because of the mechanical action of the eyelid repeatedly rubbing over the cornea. And this does improve after treating the blepharospasm. There are multiple scales that talk about the severity of blepharospasm. They take into account the severity, how forcefully the eye is blinking, as well as how frequently the eye is blinking. It might just be occasional increased blinks, or maybe increased blinks in response to stimuli. That is stage 1. Stage 2 is where the blinking is very obvious to us. Stage 3 is where there is frank spasm, but less than 50% of the time. And stage 4 is when the patient becomes really functionally blind. The eyes remain closed more than half the time. They're unable to do their daily activities. However, even with the Yankovic scale, as with the other scales, the problem is that the scales do not take into account the non-motor components. And non-motor components cause the patients an equal amount of distress. So in the differential diagnosis, you could have drug-induced dyskinesia. It could be associated with other movement disorders, psychogenic dyskinesia, and dry eye-induced symptoms, as we talked about. All of us, if we see a patient like this, we should be talking about supportive management. Now, oral medications do help, particularly in cases of lower face dystonias. I don't prescribe these myself. I take the help of a neurologist. But they're not absolutely effective. They cannot work alone. They are supportive measures. Blue wavelength blocking lenses help a lot in case of photophobia. And the photophobia is probably due to abnormal activity in the thalamus. There are specific lenses available which cut off the blue wavelengths, and nowadays they are available in India. A few years ago, these were not available. And I used to just tell them use brown tinted glasses. That used to help. That's very helpful. So this is something all of us can do. We should encourage them to use the sensory tricks. And I recall one patient who used to wear a tennis cap all the time because the elastic put pressure on his forehead. And there is recently a device that was published about that you attach to a spectacle frame, which can be adjusted to put pressure on the sensory trigger point. And I'm sure, our level of ingenuity, instead of waiting for it to come from abroad, our opticians might be able to fashion this device for our patients themselves. So for all patients, the supportive measures include blue blocking glasses, utilize the sensory tricks, and use tear substitutes because they do have dry eye. The mainstay of the treatment is chemodemonization with botulinum toxin, and this is the treatment of choice. 90% of the patients achieve significant relief. So nowadays everybody is pretty aware of botulinum toxin is. It inhibits release of acetylcholine from neuromuscular junction. But when we are injecting, remember to tell the patients the effect is not going to start immediately. It's going to start after 3 days. And the peak effect will be reached in 10 to 14 days. So you'll see a lot of patients come in for injections because they have a family function and all. Remember to tell them that when is your function? So accordingly, please calculate when you want the injection. But about 5 to 15% are not very sensitive to botulinum toxin. We dilute botulinum toxin with normal saline, never with sterile water for injection. Because diluting with sterile water for injection makes the injection very painful. We use 4 ml or 2 ml per 100 units. Often we use 4 ml, 2 ml for 50 units. That will give us 2.5 units per 0.1 ml. That's an easy calculation to remember. And even though the company says you have to use it all up, a reconstituted vial can be kept in the fridge for up to 6 weeks and it is still effective. So the available ones in India easily are botulinum toxin, Botox from Allergan and Xeomin from Hertz. But I have no financial interest and both of them are equally effective. Even though they are different categories of botulinum toxin, this is infobotulinum toxin, this is onabotulinum toxin, this is abotulinum toxin. That means the processing is different. Botox and Xeomin can be interchanged unit for unit. It's the same dose for both. This port is about 4 to 5 times more. Pre-injection, we have to talk to them about the side effects and the need for retreatment. And I always reassess them after a few weeks to finalize the optimum dose and pattern. I use a diagram like this, different sizes of crosses for different doses, 2.5 or 1.25, where I put the injection and how much I put. And then I call them back after 3 weeks and see where they should be getting more. And so this needs an idea of the facial muscles, the superciliaris colligator and the procerus orbicularis. We need to know where exactly we are giving. For orofacial dystonia, usually in each muscle we have to give 10 to 4 units. I myself give only in the masseter and the platysma. I'm a little scared of giving to the others because they can diffuse into the laryngeal muscles if I make a mistake. So we talk on the duration of maximum effect. The company once again says you have to keep giving the injection every 3 months. It's not necessarily that you have to give it 3 months. So what is better to do is to give them a flexible schedule. When the patient feels that the spasm is increasing, please come back for an injection. And I've seen more or less my patients come back to 4.5 months, which is very decent. And giving them a flexible schedule has the same efficacy, side effects are similar, but the cost of course decreases. Pre-injection, we need to make sure the patient is not on any anticoagulant because it's going to cause bruising and there will be dispersal of the injection and reduced effect. We need to make sure that the skin is healthy. We definitely don't want to carry infection from the skin deep into the deep tissues. Clean any makeup, clean the face, wipe the eye and periocular area, not inside the eye, with alcohol swabs, normal saline. We apply topical anesthesia. It's available as Prilox. And even if Prilox is not available, you have to apply it for 45 minutes. If the patient is in a hurry, use an ice pack. Hold an ice pack at an injection site for about 30 seconds, the area gets completely numbed, and then you inject. And even after injection, you can use ice packs for some time to reduce any possible bruising. So, we use 2 ml normal saline in a 50 unit vial. And when we mix it, we don't shake it vigorously, we move it gently. When we are injecting, the thick muscles you hold and pinch up and inject into the substance of the muscle. Use a 30 gauge needle, it has better control and is less painful for the patient. And if you wish, instead of taking an ordinary 1 ml syringe, use a tuberculin syringe because there's no hub, so you are not going to waste any injection inside the hub. And in the eyelids, you're making little blebs. You're just pushing it just under the skin because immediately under the skin you have the orbicularis. And in the eyelids, you see I'm putting it at the pre-tarsal areas, and we'll tell you why the pre-tarsal is so important. In the lower lid, you see I'm avoiding the medial-most area. The lateral edge is actually the most painful. So I usually avoid injecting it till the end. I do the lateral edge the last. Don't point the needle into the eye, and the lateral edge inject more than 1 centimeter from the lateral canthus to avoid it diffusing in and causing diplopia. So these are the spots we injected. Tell the patient to avoid heavy exercise and alcohol the same day and not to touch the face. Don't rub the face, don't lie down on the face, don't wash the face because you put the injections in very specific areas. You don't want them to diffuse out anywhere. And I have deliberately shown the lower face also in case the orofacial dystonia comes in. The side effects would include ptosis because of livedo. So we avoid injecting the preseptal area. That's where it can diffuse into the levator and the superior rectus. We avoid the medial side of the lower lid, which can cause ectropion and epiphora. We avoid the nasalis because that will cause difficulty in breathing. And do not inject medial to the modulus because that will cause drooping of the corner of the mouth. You can inject outside the modulus. There may be a little bit of lavocalmus, so after surgery, after the injection, always put them on droopers. So this is the patient, and you see him raising the eyebrows. That is a sign of the apraxia of lid opening. Okay, because the pre-tarsal orbicularis has to relax before the eyelid can start to open. And if that cannot relax, you get apraxia of lid opening. So it is very important to inject the pre-tarsal orbicularis. Resistant to botulinum toxin, people say people get resistance. But resistant per se is actually in a very small number of patients. It's more that the patients are getting more severe disease as the time goes by, so you need a higher dose. Nowadays, we don't use that much of the injections we get, don't have that much of protein content. Patients don't get sensitized. There's also mechanical stress. The constant spasm causes changes. It causes ptosis, drooping of the eyebrow. It causes ptosis. It causes blepharospasm. The entire skin fold hangs down. So there's excess weight for the eyelid to open. So that adds on. And there can be apraxia of lid opening, which is coexisting if you have not treated it well. So, techniques of surgery for blepharospasm. Blepharospasm is treated by surgery only when it does not respond well to chemodenervation. Earlier, there was avulsion of facial nerve drive, but it causes too much side effects and is not so effective. So, now the standard is orbicularis myectomy. You remove the orbicularis muscle only for the upper lid. So we inject Klein solution to get a bloodless bead, and you can see this is a blepharoplasty marking. We take out the skin. We are going to remove the excess weight to the extent possible. So along with the skin, the next we start taking out the orbicularis. And here we have to be very meticulous. Absolutely. See, here we are onto the tarsal plate. Everything on top of the tarsal plate is removed, maybe 1 millimeter strip along the lash margin is kept. And here you can see this is the orbital septum at the back, so there's nothing in front of it. We are also opening up and identifying the libido and reattaching it to the tarsal plate. So this is the patient we have already met. And this is how it works. What comes out of the orbicularis myectomy? All the papers of the outcomes are from 1990s. Okay, so more than 55% get relief for spasm for more than 2 years. Those who don't get relief can experience decreased dose and decreased frequency of botulinum toxin. I have a patient where we could bring down the dose from 100 units to 20 units. I have another patient who need injections every 2 weeks, but now that's spaced out to 4 months. So that's beneficial for the patient. However, the side effects known are the swelling, which is going to stay. Earlier, there used to be a lot of lymphedema because the initial patients underwent myectomy both upper lid and lower lid. So nowadays, we do only the upper lid. There can be epicura because of reduced blinking, and the patient may sometimes need ectropion and ectropion correction. However, if you look at the pattern in the curve, by about 20 months, nearly all the patients will start needing Botox again. Other modalities which we should know about because patients are going to read up and tell us. So in the 1990s, there were a lot of studies on doxorubicin. It causes chemomyectomy. It is a myotoxic anti-cancer agent. It causes inflammation in the eye up to 3 months, but the effects stay for median 3 years. And skin also shows scarring changes. So because the botulinum toxin itself is so effective, this may not be a treatment of choice anymore. Another newer modality that has been talked about is use of medical cannabis. It's not very clear how this works. However, the people who have tried it out, this is a study from Israel, they said it decreases the number of episodes significantly and decreases the duration of each episode. Yeah, and I can see people smiling at the thought of using cannabis. So, to summarize, we go into the differential diagnosis where essential blepharospasm is bilateral and stops during sleep. Reflex blepharospasm is bilateral and is eliminated by reducing light, or it is reduced by using topical anesthetic. Facial orbicularis myectomy is unilateral. There is a history of stress, there is a history of caffeine intake, there is a history of smoking. This is the first young man that I showed. This is a set-limited condition. You just have to reassure the patient. Nothing more is necessary. Hemifacial spasm is unilateral. It can be triggered by facial maneuvers. It gets worse in social situation and by talking. And hemifacial spasm does not stop in sleep. So we talked about periocular spasms and extension to other areas. We talked about motor and non-motor features, supportive therapy, chemodenervation with botulinum toxin, and orbicularis myectomy. Thank you.
Thank you very much, ma'am, for that very engaging and educated talk. Any questions from you?
Can we once you open a vial of Botox, how long can we keep it in the, like if we don't have here you know you get patients once in 3 months, once in 4 months.
So you can actually keep it easily for 4 to 6 weeks. So maybe not 3 months.
And other be cheaper option because Botox costs about 10 to 12,000 per vial.
Yeah. So I have not used them myself, but there are a couple of other brands, Botulinum and Neuronox, and those who use it are quite happy with it. Maybe the patients need a little more frequent injection, but they work.
And sometimes these patients, a lot of patients come with very vague lid twitching. So they just say that lid is twitching. So I mean, we might find it very silly, but they actually are stressed about it.
the sensation of lip twitching is more likely the category of the facial myopia or conjunctival myopia. I think it is more like, reassure them. And nowadays, if you ask people, I think 90 out of 100 will tell you, oh yeah, I'm not sleeping well. Oh yes, I'm stressed. Oh yes, I'm overworked. But just like we were talking about the in the previous talk, I think lifestyle and stress do play a role in these situations.
Ma'am, hello. Ma'am, I gave a Botox and then 1 week I called the patient for follow-up. But patient is having residual, residual twitching and patient is worried about it. So how do I augment and when do I
So to begin with itself, you tell the patient that the first, because each person needs a different dose. Okay, so you tell them the first injection is based on your idea of the average dose, but you want to see them after 3 weeks so as to you decide on the final optimum dose. So they know in their mind, okay, you're starting with 20 units or 25 units. Okay, we'll come back and depending on how much the action is, you tell them that next time we might be giving you more or we might be giving you less. And tell them that we will finalize the dose and the pattern. And then the patient is very happy that you have a tailor-made injection schedule for the patient. Sir?
Children, 5 and 10 years. Teaching. They disappear on their own after 1 month or 2 months. We concept assessment.
Sir, I think in a lot of children, it is more like habit states. So they get into the habit of doing it. So instead of stressing on that and pointing it out, we just tell the parents, okay, let it be. We watch. It settles down.
It's clear that you follow the severity assessment.
Sorry?
This case that you follow because I used to follow, I approach suggestion about I used to follow some scales. Assess the severity of the blepharospasm and for the next follow-ups of the C because many patients they give estimation of some toxin and they also send for the secondary evaluation to patients. Because probably they say the think that it's because of some secondary illness. Many times they have chemical issues and all. Many times I feel like patients in blepharospasm also take a secondary.
Then here, a lot of the patients do have a component of anxiety and depression, panic attacks. So when we are talking to the patient, it makes sense to spend time and talk to the patient. And if you see these components, it helps to have the psychiatrist also take care. Let's remember that psychiatric treatment alone is not going to cure the spasm. But part of the non-motor effects is the distress, the worry the patient is feeling. And yes, that should be taken care of.
Due to time constraints, we will have to try to stick to the schedule. We will be having a dedicated Q&A session in the end. Thank you very much, ma'am.
Thank you.
We will be grateful for you, ma'am, for 10. I would request the audience to please come back.
Yeah, so you can see that there is a loss of the architecture of the retinal layers here. There is a hyperreflectivity or a whitening of the retinal layers on the OCT. So this helps to pick up a retinitis. So here it is involving only the inner layers, the inner retinal layers, whereas here it is involving both as the inner as well as the outer retinal layer retinitis. There is also an outer layer retinitis as can be seen in syphilis as already told by Dr. Kalpana. So that is relatively less common. Most of the retinitis are mostly inner layer retinitis or a total layer retinitis. So retinitis can be infectious or non-infectious. Important infectious causes I'd like to stress upon rickettsia in the bacterial group. I'd like to stress upon herpes zoster virus, varicella and CMV in the viral group. And important one in the protozoa is toxoplasma gondii. Among non-infectious causes, I'd like to stress upon Behçet's. Though Behçet's disease mostly presents with vasculitis, the second most common manifestation after vasculitis is retinitis in Behçet's disease. So, what else looks like retinitis? Most often we find that it is not something else being diagnosed as retinitis. It is that retinitis gets misdiagnosed as other things. So retinitis can be commonly confused for choroiditis, for cotton wool spots, for myelinated nerve fiber, for retinal vascular occlusions. So most of the time it is misdiagnosed. So it is a very important slide. So how to differentiate between retinitis and choroiditis in your clinic? So retinitis is most often whitish. It is at the layer of the level of the retina. So you can see that it obscures the retinal vessels here. Okay, and it generally has very poorly defined borders. Okay, and there's a lot of overlying vitritis. Whereas if you see this image, this is a choroiditis. So you can see that the images are the lesions are very well defined. They are usually subretinal. How do you identify the subretinal? You can see the retinal vessels are clearly crossing over them undisturbed, as if nothing happened to them. So you can see these are choroidal lesions, well defined. They are more yellowish when compared to retinitis, which is more whitish. So they are usually more well defined, and there is not that much of vitritis when you see retinitis. So this is a very important slide. So this is one of my patients. This is actually a case of choroiditis. So this is a case of serpiginous choroiditis. So you can see these well-defined lesions here, subretinal, yellowish. Okay, and at the time of presentation, you can do an OCT. When in doubt, do an OCT if you have an OCT. You can see the retinal layers are very neatly arranged here, except for some disturbance here. But you can see the choroidal vessels are all congested, they are dilated. So you can see here. This is at 1 year follow-up. This patient was diagnosed to be quantiferon TB gold positive. He underwent a 6-month course of ATT and then received steroids. So you can see that the lesions have all resolved here nicely with scarring. And this patient's vision improved from 636 to 69 in over a course of 1 year. So at the 1 year follow-up, you can see that the choroidal vessels, you can see the difference in thickness here from this image to this image. You can see the outer choroidal vessels are very nice and neat and not dilated and congested like here. So this is a choroiditis and not a retinitis. It's very important to differentiate between these two. Another important differential is cotton wool spots. So most of the time retinitis is misdiagnosed as a cotton wool spot. Sometimes cotton wool spots can be present even in case of retinitis. Now remember, cotton wool spots alone usually they're mostly bilateral. They are associated with diabetic retinopathy. More importantly, with hypertensive retinopathy. So you have this very angry looking retina here, with a lot of flame-shaped hemorrhages and a lot of cotton wool spots. This patient has a BP of around 200 by 120. So you find this is a typical grade 3 hypertensive retinopathy. So cotton wool spots don't occupy a very large area. They're usually very small. They have blurry cloud-like edges. Okay, they look like clouds basically. And they're smaller in size compared to retinitis. They're more yellowish compared to retinitis. So you can correlate them with the general picture also. So myelinated nerve fiber. So these are usually commonly present. So they are asymptomatic. They're chalky white. They're most often situated around the optic disc or along the arcades. So they follow the architecture of the nerve fiber layer. So they're usually asymptomatic. There's no vitritis. The patients have no complaints here. Okay, so this is a scarred CNVM at the macula. So you can see in the CNVM it's usually subretinal. There's some pigmentation here, RP changes. Okay, so sometimes you can find subretinal hemorrhages around these lesions. Here it's not there, but you can see sometimes subretinal reddish streaks around. So that tells it's a CNVM and not a retinitis. Uh, then this is a vascular occlusion. So very often retinitis is misdiagnosed as BRAO. So the thing is, with vascular occlusions, there's a retinal pallor. It follows the direction of the vessels. If you do an OCT, you will find an inner layer hyperreflectivity just like in retinitis. But the thing is, the retinal layers are very nicely organized here. They are not disorganized like in case of retinitis. The architecture is maintained, just that it is more pale. So this is a retinal vascular occlusion and not a retinitis. So most of the times, like I told you, retinitis is misdiagnosed as other things. The chances of other things being misdiagnosed as retinitis is very rare. So this is a patient I just saw yesterday actually. It's a 15-year-old boy with a Coats disease. So you can see these telangiectatic vessels and you can see this subfoveal exudation and lipid exudation here. So this is a subretinal lipid exudation. You can see the retinal vessels are neatly crossing over it without any disturbance. So this is not a retinitis. So this is lipid exudation. It can occur in Coats disease or even in retinal artery macroaneurysms. Okay, so these are the important differentials to consider. Now let's go to a very interesting case. So this case you would have probably seen lots of these in your clinical practice. So it's a 56-year-old lady with a history of fever, blurring of vision in the left eye since 3 days, a fever history of dating back to 3 weeks ago from the time of presentation in your clinic. So she had right eye had a normal vision, whereas left eye had 2/60 at the time of presentation. So if you see the picture here, the fundus picture, typically you can see these yellowish white spots here, patches here. You can see a lot of retinal hemorrhages here, and you can see these macular star hard exudates here. If you do the OCT, you can find a disorganization of the inner retinal layers here. You can see these whitish dots in the vitreous. Can you appreciate that? So these are vitreous cells. These are very useful to identify if it's inflammatory pathology or not. Another important clue, see the subretinal fluid, there are some whitish specks here also. So again, these are hyperreflective dots. These are also indicative of an inflammatory pathology. So it is very useful to identify. So this is a case of post-fever retinitis actually. So we did the usual uveitic investigations. I also had included toxoplasma and veil Felix test. This patient had a positive veil Felix test. So she was started on a course of doxycycline 100 GBD for 1 week, followed by oral steroids. Also, she was given a posterior subcutaneous injection of triamcin alone. So, following which vision drastically improved to 660 in about 2 weeks. You can see subretinal fluid has significantly decreased. It is not totally gone, there is still some amount of fluid here. But you can see the retinitis patches and the hemorrhages, they are neatly resolved within a span of 2 weeks. So this is at 6 months follow-up. You can see that she had a vision of 624. She had some amount of foveal thinning, some amount of ellipsoid zone changes here at the fovea. So this is a common occurrence in retinitis because of all the damage that has occurred. So this can present as a late sequelae. So I would like to, this is a typical case you'll see in a clinic. It's called as post-fever retinitis or epidemic retinitis. So I would urge you all to read this article on post-fever retinitis by Dr. Padma Malini. It is in IJO 2020. It's a very nice article. So it's an infectious or a para-infectious entity which is caused by bacterial or viral agents and seen mainly in the tropical countries. Important causes are rickettsia, typhoid, dengue, chikungunya, Zika, and West Nile virus. So it is mostly as a result of immunogenic reaction. So it occurs 3 weeks after fever. So usually, if you ask them, they may give you a very vague history of insect bites. Sometimes people don't even remember. But if you probe, they have an history of entering the forest or a history of going on a trip to waterfalls. So if you actually probe, you might find this. Sometimes you may not find this. Not mandatory. So in India, Indian tick typhus rickettsia conuri causes this. So you can see a retinitis of the inner retinal layers here. So, like I told you, it presents 1 to 3 weeks after fever. There can be some amount of retinal hemorrhages along with the retinitis patches here. Okay. So, this is one more patient, very subtle post-fever retinitis. There is a proper history of fever. This almost looks like a corneal spot, but if you do an OCT, you will find these hyperreflective spots here. So, this patient received a subcutaneous injection of triamcin alone. It resolved actually. So it's a very subtle one, but with proper history taking, you can pick it up. So they have some symptoms. A weak Felix test is usually positive with a titer cutoff value of 1:80. So doxycycline 100 mg for 2 weeks followed by oral steroids can be given. You can also use ciprofloxacin as alternative. So you can add posterior subcutaneous injection of triamcinolone for faster resolution of macular edema. Now, this is about most of them have a history of typhoid also. They will actively come and tell you they just recovered from typhoid. So you can have this presentation post typhoid. In dengue, what I found from looking up online is you will find something called as foveolitis, which is a subfoveal outer retinal lesion. It's called as foveolitis. It's seen in dengue. So another important thing I would like to stress upon is neuroretinitis. Now most of the times the term neuroretinitis and post-neuroretinitis are used almost interchangeably. But in neuroretinitis, what I like to highlight is mainly there's a lot of disc edema. It has an optic neuritis like feature. There's a lot of color vision loss. There's a lot of decrease in the visual acuity. There's disproportionate color vision loss. So there's a disc edema with the surrounding exudative RD, which causes a lot of hard exudates later with a macular star appearance. Initially, you may not find this. Initially, you may just find a disc edema. After a few days, you will find the macular stars. So, in our part of the country, tuberculosis is a very important cause. Another important cause is blepharospasm, especially in our Malnad region, where there is a lot of farming, and in rainy season, where there are a lot of paddy fields. So, these farmers get infected because of wounds on their feet. So, the rat urine is supposed to be an important proponent of this. So the water contaminated rat urine comes into contact with their feet. So that's how they acquire leptospirosis. Where I did my internship in Mangalore in Dakshin Kannada. So in our government hospital is filled with leptospirosis patients in the monsoon season. So it's very common occurrence in our part of the country. It can cause neuroretinitis. Okay. So coming to another important topic, which is toxoplasmosis. It's a causative agent is Toxoplasma gondii. So you can acquire the infection from eating undercooked meat. Also, if cat feces contaminates the water which you are drinking, or sometimes even raw vegetables which you consume, which is contaminated with cat feces. And it can also spread by organ transplantation, blood transfusion, and of course from maternal to fetus transmission. So there are two types, congenital and acquired. So congenital has a triad of retinochoroiditis, intracranial calcification, and hydrocephalus. Now, clinically, how do you identify? So, you can see most of the times it involves the posterior pole. It is limited to the macula or around the arcades. You can find these well-defined retinitis patches. There may be a localized vitritis overlying it. This is a very important sign to identify. So, another thing is anterior uveitis may or may not be present. It's not mandatory that it has to be present. Sometimes you can find these scars, these atrophic scars with punched out scars with the pigmentation at the edges. And you may find lesions adjacent to it which get reactivated over the course of time. So you can have this presentation. So again, you can have punched out scars. Sometimes you can have periarterial lipid depositions. And the classical textbook description is the headlights in the fog appearance, where the headlight is the retinitis and the fog is the vitritis. But generally, in clinical practice, you will not see this much of vitritis. So you will usually see a localized vitritis over the area of the lesion. So this is one patient I had seen in a fellowship actually. So this is an active retinitis. You can see on the OCT there is a inner layer retinitis here. The retinal layers are fairly disorganized. There is a hyperreflectivity of the retinal layers. Okay, so lesions close to the optic disc can present with significant visual field loss. So on OCT, you look for hyperreflectivity of the retinal layers. You look for thickening of the posterior hyaloid. Okay. So over a course of time, it becomes an epiretinal membrane. So you can have all these changes that can occur in the chronic phase. This is another patient. So post retinitis, the lesion has healed very nicely. You can post toxoplasma retinitis post treatment. So investigations, normally you can do an IgM and IgG for antibody to toxoplasma. Serum IgM elevated levels indicates a recent infection, whereas IgG indicates a past infection. In immunocompromised or HIV patients, serology may be negative. In these patients, it's a good idea to do a PCR, take a tap and do a PCR. So you may find it to be positive in case you're suspecting. So now when to treat? So they normally say it's self-resolving in immunocompetent patients, but most of the times you will end up treating them because most of the times they are lesions which are threatening either the fovea or the optic nerve. They usually present to you because they have visual symptoms. They have lesions greater than 2 disc diameters. When there is a disease for more than 1 month, when there's a drop in visual acuity less than 612. So these are indications for treatment. So treatment is very simple. You can treat them with cotrimoxazole, which is a combination of sulfamethoxazole and trimethoprim, double strength. So it is available as Bactrim DS. So you do it in a course daily for 4 to 6 weeks. Once you start it, after some 5 to 6 days, you can start the oral steroids also. It helps to control the vitritis. For recurrent toxoplasmosis, you can use Bactrim DS once in 3 days for a long term. So if your patient has sulfa allergy and cannot tolerate sulfamethoxazole or cotrimoxazole, so you give them clindamycin. You can also give azithromycin. Nowadays, people are preferring using intravitreal clindamycin, intravitreal injections at a dose of 1 milligram and 0.1 ml, along with intravitreal dexamethasone. It is found to be equally effective as a systemic therapy actually. So in pregnancy, you can use pyramycin. When somebody is planning a pregnancy and they're infected, so it's better you can use pyramycin. Or safer, you can give intravitreal clindamycin with dexamethasone. So in immunocompromised, remember that you have to give them systemic therapy because chances of CNS toxoplasmosis is very high in these patients. You can also use atovaquone, which is an anti-malaria drug, which is used 750 milligrams QID for 3 months. So coming to the last part, that is viral retinitis. Now, among this, I would like to talk about ARN in detail. So it is mostly caused by herpes simplex and varicella zoster virus. It is seen in immunocompetent as well as immunocompromised patients. So varicella zoster virus can also cause this. So it is because of direct viral infection, or it can also be because of an immune-mediated obliterative arteritis. Okay. So remember in anterior segment, most of the times there will be anti-uveitis, but sometimes there may not be. So look for high IOP to the tune of 40, 45, 50. So these are all very suggestive of a herpetic infection. Even in herpetic anterior uveitis, if you sometimes find very high IOP. So look for this specifically. Look for scleritis. So there is the American Uveitis Society criteria. More importantly, I'd like to stress upon how ARN present. So mostly it starts in the peripheral retina and then progresses to the posterior retina. It has a very circumferential spread and then it progresses more posteriorly. It has a very scallop margin. You can find this convex margin here. So it spreads from periphery to the central retina. There is a lot of vitritis here in ARN. Okay, so this is the active phase of retinitis. Like I told you, the multifocal yellowish white patches. They are confined concentrically and then they spread centrally. Okay, so all layers of the retina are involved here. So sometimes you can have this perivascular clearing, which is gives it a cracked mud appearance. And a lot of times ARN is associated with optic neuritis also. So in all viral retinitis cases, it is better to send AC tap for PCR, mainly to differentiate between herpes group and cytomegalovirus retinitis, because the treatment is different for both of them. So eventually, if left untreated, what happens to ARN is it goes into this chronic stage, where the retina becomes very thin, pale, yellowish, atrophic. So you find a lot of retinal holes at the junction of normal retina and the affected retina. So the retina has a Swiss cheese appearance, a lot of pigmentation, a lot of tiny holes forming up here. Eventually, these patients go into rheumatogenic retinal detachment. In fact, a lot of them go into rheumatogenic retinal detachment. I'd like to thank Dr. Giriraj Vibhuti from MM Joshi Institute, Hubli, for providing me these beautiful those images. So you can see that there is this peripheral retinitis that is slowly creeping up to the center. The fovea is right now still unaffected. So you have a very sieve-like retina, which eventually worsens. You can see the scallop border here. So you can see there's a lot of vitritis, there's a lot of optic neuritis also. So this patient had a lot of multiple small holes and was taken up for vitrectomy. This is post-vitrectomy, there's a silicone oil filled eye. You can see there's a little bit of this pallor here, post-resolution of the optic disc edema and all that. So most of they need surgical treatment. Sometimes they can go into PVR and again redetachments. So remember in ARN, look for meningeal signs, look for neurological symptoms. They can have meningoencephalitis. So they will need systemic treatment. So you can treat them with IV acyclovir or oral vanillin. Remember, acyclovir is hepatotoxic, so monitor the LFT and RFT. Oral steroids can be given to control the inflammation after 48 hours of starting acyclovir. And intravitreal medications can be given for sight-threatening lesions. You can give intravitreal ganciclovir. So, retinal tears, like I told you, occur at the junction of normal and necrotic retina. It can go in for combined RD, rhegmatogenous, fractional RD, proliferative retinopathy. So RD is seen in almost 75% of the cases according to some of the studies. Involvement of the second eye can be seen in 36% of the patients, but most of the times ARN is usually unilateral. So coming to another entity which is PORN, this is relatively rare. So this is caused by varicella zoster virus. It is usually in HIV patients with a very low CD4 count below 50 per microliter, and it has a very extremely rapid course. So you will find these patchy